So I want to introduce Dr. Danny Gonzalez. Dr. Gonzalez is the director of the neurology residency program and a neurologist in the Petsnick Stroke Center here at Barrow, as well as an assistant professor in the Department of Neurology. His expertise includes the diagnosis and treatment of stroke and other neurovascular diseases. He's a member of the American Academy of Neurology and the American Heart Association. He earned his medical degree from Texas A&M College of Medicine and completed his neurology residency and a vascular neurology fellowship here at Barrow. Welcome, Dr. Gonzalez.
Thank you so much, Suzanne. I'm pretty sure you guys can hear me okay. My name is Danny Gonzalez. Thank you so much for that introduction. My two passions lie in education, teaching, and also in the treatment of patients with stroke. So without further ado, I'll get started by quickly describing what is a stroke. And it's not very often that I get to talk to a patient or patients or people that have not already suffered this terrible disease process. So stroke deals with the intimate connection between the heart, the pipes in the neck, the arteries in the head, and the brain. And when patients have either decreased blood flow due to an obstruction in one of those arteries, or too much blood flow due to a rupture of one of those arteries that causes a hemorrhage in specific locations of the brain, we refer to both of those events as a stroke. When there is too much blood flow or too little blood flow in a portion of the brain, the patient will develop neurological symptoms. And that's the basics of what we're going to talk today and how to prevent it. So, as we know, stroke is the fifth leading cause of death in the United States, but unfortunately, the number one leading cause of disability. And the reason we discuss this is because strokes do not take many people's lives, as we see. There's the fifth leading cause of death, but the number one way to become disabled. And there are certain types of strokes that can knock out entire parts of the entire sides of the body, say the ability to move the face, the arm, and the leg, or leave you with difficulty speaking, leave you with difficulty swallowing, or performing your activities of daily living. Now, we have learned how to primarily prevent stroke over the course of time, say with adequate control of blood pressure, ensuring that your high cholesterol is controlled, and also ensuring that we don't develop disease processes that are difficult to control, such as diabetes. These referred to as modifiable risk factors, and much of what we're going to discuss today is going to be how do we modify and control those modifiable risk factors. But there are some risk factors that are innate to us, say mom and dad, grandma and grandpa on both sides, that we cannot change. One of them, say, being age, one of them being male, female gender, and also the genetics that we were blessed with. Some of us are predisposed to get diabetes no matter what we do. Some of us are predisposed to have high blood pressure or cardiac disease. But there are many ways that we can get in front of that and ensure that we put ourselves in the best possible position to not have a cardiovascular disease or cardiovascular event, such as heart attack or a stroke. So as we go through this discussion, I want to simplify things as much as possible. We as stroke neurologists do a very good job of oversimplifying things for the sake of understanding, for the sake of studying, and for the sake of identifying treatments that can decrease the risk of this happening again. So if you know this, you know a lot of stroke. If you know this basic concept, that stroke comes from four different places. Clots, lack of blood flow that cause lack of blood flow strokes, ischemic strokes come from the heart. They come from the arteries in the neck, the arteries in the head, or if you were born with a propensity to form clots. We refer to this as cardioembolic strokes, strokes due to atherosclerosis in the large arteries in the neck, and strokes due to small vessels that are diseased and located inside of the brain. Lucky for us, we're able to identify which types of heart problems can cause strokes and treat the disease processes that lead to cholesterol formation, say high blood pressure, high cholesterol, in both the large arteries in the neck and the large arteries in the head. When we are able to identify the pathway, the cause of this stroke, we really do our best to understand the history of the patient. Now, patients come with their own background. And in order for me to understand what's going on right now, the course of the developing disease, I need to understand what's going on with the patient. And we do this by asking you simple questions. When you go into your doctor's visit, there's not going to be any interaction that you have with a doctor where you don't start off by identifying your medical diagnoses. Now, I will say just because we haven't been to the doctor doesn't mean that we have medical diagnoses. And blood pressure being elevated changes throughout the day. So, in simple, stressful situations, such as the early morning traffic in Arizona, or even simply having to go use the bathroom, those little items, those parts of your activities of daily living can increase your blood pressure. And for some of us, that increase in blood pressure remains sustained throughout the day. And it's those sustained elevations in blood pressure that we need to figure out. So in those medical, it's very important to ensure that you know what your blood pressure is, what your cholesterol is, or what your sugar level is. In addition, simply understanding how you eat, how you move, say exercise, or do you live a sedentary lifestyle without exercise or movement because of the job you do? Those simple 5 things, understanding your blood pressure, cholesterol, diabetes, your movement, your ability, your what you eat and intake on a daily basis. That goes a long way in setting up the stage to ensure that you're getting the most out of this clinical appointment. Secondly, would be your medications. Medications come in all shapes and forms. It's very difficult for us to identify a medication based on descriptions such as that little blue pill. So, coming in with your medication bag, or at least a schedule of medications on a timeline or a piece of paper, Monday through Friday, where we can say, okay, this is the medication, and this is the dose, and this is when I take it. The reason this is so important is because we are able to then look at the medication regimen that you're on, identify if your blood pressure or your cholesterol is controlled or uncontrolled, and then make a much more data-driven decision for your individualized healthcare. At the end of the day, this is your blood pressure, not ours. This is your cholesterol, not ours. And we want to empower you to make the right decision for yourself with whichever physician you are seeing. The third part of the background that we really want to hone into is going to be your family history. And not many of us are as fortunate to have this understanding based on different backgrounds or upbringings, but understanding if mom or dad are simply still alive, what medical problems they have, or what medical problems your grandmother or grandmother on both the maternal and the paternal side suffered from. The reason that we use this information is because this allows us to start thinking, okay, does this patient or does this person have a propensity to have early onset cardiac disease? Do they have a really strong family history of stroke before the age of 55? Or do we need to place this patient on certain medications or start diagnostic testing just a little bit earlier because of this strong pattern that we notice in your family history? Believe it or not, it goes a step further. Where you live has a lot to do with your risk for any type of disease. And say recently, Barrow specifically published something along the lines of an association that exists with living close to a golf course and potential neurodegenerative disease. Well, believe it or not, stroke risk and exposure can increase stroke risk. If you're living next to a factory that produces a lot of air pollution, if you're living next to animals or livestock, or people that simply smoke cigarettes and you're getting secondhand smoke, those are environmental factors that require your awareness and your ability to let and verbalize that to your physician so we can determine, okay, this is where the risk factor is coming from. We need to identify that and remove the patient simply from that environmental stimulus and get them away from that to decrease the risk of cardiovascular disease. Now, your environment also includes your spouses, that includes your wife, your husband, your kids, and them simply hearing you sleep goes a long way in decreasing your stroke risk. And why does one think that? We spend 1/3 of our lives in sleep. And if we are having issues with obstruction of the airway due to, say, neck circumference, or simply the anatomy that we have, and we're snoring in our sleep, waking up in the middle of the night, gasping for air, If you try and just do that now for 10 times in a span of 30 minutes, what you'll see is your blood pressure rises and your heart rate rises, and the stress on the cardiovascular system increases. Simply having a video of you sleeping, although creepy, is a good way to assess how you spend 1/3 of your life. Now, lastly, what we want to do is make sure that we understand who you are as a person. If you're working, say, in a coal mine, or you're working a sedentary job, or you're exposed to infectious diseases because you travel, say, to Africa and to other sides, third world countries, or whatever it may be, we need to know about that. That is one of the most important things that you do to put money on the table to protect your kids. And my job as your stroke physician, or as your physician in general, is to make sure that I take into account what you do on a daily basis and keep you doing that specific job or specific work, because that's something that you're likely passionate about. The reason I bring this up is because stroke affects patients in their most vulnerable times of their life. They're either bringing in children into this world, developing those children into the college athletes or college academics that they're going to be. They hold prominent leadership. They're prominent leadership figures in their communities, say pastors or mayors, and even very famous people that have it all put together and do things like exercise on a daily basis can be affected by stroke. Say some famous actors that have recently been affected with this disease process, or a basketball coach, Greg Popovich for the San Antonio Spurs. This is a very real disease that affects the general population. And our job is to, one, understand that stroke comes from four different places: the heart, the vessels in the neck, the vessels in the head, and obtain your patient background or your personal background, including your diagnosis, your medications, what you do on a daily basis. That also includes where you live, how you sleep, and what environmental exposures you have. Now, we do all this to then ensure that if a patient has signs or symptoms of a stroke, or simply wants to assess their risk, we use this background and this knowledge of the anatomy to develop a diagnostic plan. And believe it or not, the diagnostic plan follows the same four steps, or the same four locations, that lack of blood flow, ischemic strokes, come from. Now, patients may have strokes due to the heart. Therefore, a simple diagnostic test that we've been using forever, such as EKGs to assess the heart rhythm, or an ultrasound to assess the function and the structure of the heart in real time, go a long way in giving me information about a patient's cardiac status. If we get in front of it early, we're able to say, okay, this patient has a long-standing history in their family of early cardiac sudden death, and we want to make sure we get them to the cardiologist to get a full evaluation that includes a stress test or whatever it may be, to, one, provide you peace of mind that your heart is functioning okay, and then two, to decrease your risk of having that same event happen to you. In addition, if patients come in and they say that they've smoked tobacco for a long period of time, they vape, they use oral nicotine in the form of chewing tobacco, we want to make sure that we not only assess the heart, but we take a picture of the arteries in the neck and the arteries in the head. And we can do that in many ways, one being an ultrasound of the arteries. That ultrasound gives us good diagnostic information about how fast blood flow is moving through there. Therefore, is there any blockages that live in that area? But also, a simple CT scan, a CTA, which stands for artery, a CT of the arteries. If we get that simple scan of the arteries in the neck and the arteries in the head, we are then able to actually visualize the heart, the electrical function of the heart, the structure, the function of the heart with an ultrasound, and look at the morphology of the arteries and ask questions such as, do I have anything that I was born with that shouldn't be in there that's causing a disruption in flow from point A to point B? Do I have any atherosclerotic plaque that has developed from my chronic cigarette usage, or my vaping, or my nicotine usage? And if so, if any exist here, do we see the same kind of pathology that occurs in the arteries that give blood flow to the brain that are located inside of the skull. Now, this allows us to then look at you, use your back, look at your arterial morphology, your cardiac workup, look at your background, and then give a good assessment of stroke risk. The final thing that we do is we love to look at the brain itself. And in this day and age, MRIs are becoming very easy to obtain for much of the patient population, and not all. The ones that live in like a city or non-rural areas, it's probably much easier to obtain an MRI. But just because you live in a rural area does not mean that you can obtain an image that allows us to look at the brain in much more detailed fashion. Now, we have different ways that we do this. One is a simple CT scan of the head, which is like the workhorse of what I do on a daily basis. It's very easy to obtain, about 3 to 5 minutes, and we get a scan. An MRI gives us a much more detailed look that allows us to look at the history of the brain. Have you suffered any damages previously or clinically silent strokes? Or is there any evidence of high blood pressure that has affected your stroke or affected your brain, or high cholesterol that's affected the brain? And if you've had blockages in the arteries, can we look at specific patterns of damage that then make us really worry or confident that we need to do something to these specific arteries, either surgically or medically, to decrease one's risk? The diagnostic evaluation of the patient also includes simple labs where we can see how the blood is working. We answer questions simply, what is my red blood cell count? Is it too high? Is it too low? Is it normal? Do I have a good amount of white blood cells that is within the normal range? Or am I lacking? Or am I being overproduced, such as in some cancerous processes that people may suffer from? Secondly, is we want to know simply, what is the cholesterol doing? What are the triglycerides? What are the good cholesterol and bad cholesterol, and how are they behaving in this specific patient? And then lastly is, what are the sugar levels? We use one lab called an A1C that gives us an indication of how the sugar has behaved over the course of 3 months. So this is a comprehensive diagnostic evaluation of a patient using the knowledge that strokes come from the heart, the vessels in the neck, the vessels in the head, an ultrasound and EKG, some imaging study of the arteries, whatever it may be, an MRI, and labs then put us in a position to optimize your risk factors. Now, everyone always asks, what is the role of nutrition in decreasing stroke risk? There are two main diets that the American Heart Association has really supported over the course of the last years. And those are the Mediterranean diet, which is a diet that emphasizes a high usage of, say, olive oils, high fish consumption, low consumption of red meat, and ensuring that your plates, for lack of better words, have lots of color. That Mediterranean diet is our only diet that has been shown to decrease your risk of cardiovascular disease. In patients that have high blood pressure, the DASH diet, meaning decreasing your salt consumption to 1 gram a day, has been beneficial in ensuring that these patients keep their blood pressure controlled. Now, there are many fads that have gone on, that are gone around, that are effective for goals. So you may hear about fasting, you may hear about the keto diet. In specific goal-directed medical therapy, these diets may be beneficial. For the reduction of cardiovascular risk, the Mediterranean diet is the diet that we recommend to all of our patients to adhere to follow, to decrease the risk of cardiovascular disease. One of the main risk factors that we talk about in our clinic with our patients is physical activity. And moderate intensity, 20 minutes, 2 to 4 times a week, is better than none. Your worst workout, I always say, is better than no workout at all. Physical activity, or making sure that you are active throughout the day in some way, shape, or form, is important. Now, it's again, different programs such as weight training or cardiovascular training like running, the elliptical, those are specific to what the patient's goals are. We can only recommend physical activity of moderate intensity 4 to 5 times per week is beneficial in decreasing one's cardiovascular risk. So whatever it may be, don't be overzealous and go try and do something from 0 to 100 very quickly. But I'd rather a moderate, graduated approach, such as stretching first, simple walking, simple jogging, followed by a training program where you adhere to a specific program that is guided by a medical professional. Number three, one of the main risk factors that we wish to optimize is smoking cessation. Now, we know that many of us grew up in the 60s, 70s, 80s, where smoking was just part of the culture, until we found out that the risk of lung cancer was elevated significantly in patients that smoked. Now, people do still get lung cancer even in the absence of smoking, but the lung cancer incidence has reduced due to this. Now, similarly, in patients that smoke, their risk of having a stroke is elevated. And the reason being is because that nicotine is very damaging to the arteries. They don't like that nicotine at all. And their only way to fix that damage is by forming those atherosclerotic plaques, those cholesterol plaques, kind of like fixing a drywall with plaster. But doing that over and over and over again on both sides of the arterial walls decreases the size, leads to potential little particles entering the circulation and causing those types of strokes. And lastly, sometimes our blood pressure goes down and we can suffer from signs and symptoms of these strokes because the arterial walls are so damaged from that cholesterol from that smoking, and that can lead to stroke as well. So avoidance, cessation is the best policy. My goal is to make sure that you trust your physician as trust me as much as possible, that I am giving you the best goal-directed, evidence-based research recommendation that I can in terms of smoking, but ultimately it's up to the patient to ensure that they're ready to take this on head on. Now, substance abuse comes in many forms. Intravenous drug use, stimulant drug use, and also alcohol, binge drinking specifically, is deleterious for your health. Now, the American Heart Association currently recommends 1 drink for men, 1 drink for women, 2 drinks for men on a daily basis. But what we know is abstinence, again, is the best policy. So if there's any type of drug use, specifically illicit drug use, those are the ones that we identified pretty easily. But doctor, what about this supplement? I started taking this at the recommendation of one of my friends, but I don't really know if it does anything. It's supposed to be helpful for this. We hear that all the time. Being armed with the knowledge of what you're taking is the most important thing that you can do. So if you have a question about a supplement, please do not begin anything without seeking the advice from a medical professional. And we will tell you, okay, this has been shown to be deleterious to your health. Actually, this may be helpful. Or to be quite honest, not many people take this. So I don't know. I don't know there's a risk for stroke. The illicit, like we mentioned, the illicit drugs are very easy for us to identify, but the ones that are taken in supplementation over the counter, those are the ones that we want to make sure that you are very honest with your physicians about what you're taking. Simple things such as replacement therapy, such as estrogen, such as testosterone, those occur in the age group above the age of 45, 50, and 60, or in the population that is working out and wants to achieve a certain type of goal. Talking to your medical professional or ensuring those are being managed by a medical professional is paramount to decreasing stroke risk. We continue with blood pressure. Now, anytime a patient has a risk factor, we want to determine, one, are they on the appropriate medication based on their background? And then two, are they controlled or uncontrolled? So we like using goals, targeted goals for stroke care. And one of those goals is your blood pressure goal. A blood pressure goal less than 130/80 on average is going to be the goal for control blood pressure. Now, I can safely say that I would probably say that my personal blood pressure on average is 130/80, but in high stress environments, I know that blood pressure increases. This is why it's important to understand how much stress is your job putting you under. Are you having difficulty sleeping at nighttime? Because that blood pressure can increase at nighttime. Are you having difficulty with simply activities of daily living? Do you work a lot, lift a lot of items? And how is that going for you? Do you develop headaches at the end of the day? Those are all functions of your current blood pressure at that time point. But taking your blood pressure in the morning, at nighttime, on a consistent 7 to 14 day basis gives us data that drives decision making. That way we can look at the timeline of your medications and say, you know what, your blood pressure is increasing at nighttime. I think we need to add another medication, or simply increase the dose of the medication that you're already on. Blood pressure need be controlled less than 130/80 on average over a long period of time to mitigate your risk of having another or first cardiovascular event. Now, the second item that we talk about that produces a lot of stress within the arteries is going to be high cholesterol, and specifically bad cholesterol. This is a function, yes, of diet at times, and there are times that we can achieve diet control, specifically in our patients that are less than age 40. Now, the unfortunate thing is that we likely don't catch this in much of our patient population until they've already had an event that has been, again, deleterious to their health or affected their quality of life. Getting in front of controlling blood pressure and getting in front of controlling their cholesterol. Those two items are the two main things that increase the oxidative stress that occurs within these arteries. They're the two disease processes that form these atherosclerotic plaques and can increase one's risk of heart attack and increase one's risk of stroke, whether it be a lack of blood flow stroke or too much blood pressure can lead to rupture and unfortunate hemorrhagic or bleeding events that occur within the brain and can be catastrophic at times. So again, your goal is to not only understand if you have high cholesterol or high blood pressure, the goal is to understand, am I controlled or not controlled? Because years of control decreases one's risk of having a cardiovascular event. The third disease process that we will discuss is going to be sugar levels, and that's glucose. Glucose comes in many shapes and forms. And right now, in this day and age, we are becoming much more educated on what our glucose levels do on a daily basis with the advent of simple glucose monitors that you place to the back of your arm. It is very good to be educated on what your body does in response to what you're putting into your mouth. Nutrition is an item that we do not discuss as often as we should. What is the makeup of your plate? How much of it is fats? How much of it is carbohydrates? And how much of it is protein? Now, we want to make sure that we limit the amount, not completely eradicate, but limit the amount of those macronutrients based on your needs. So simple classes of nutrition go a long way to teach what the makeup of your plate may be. The average American diet is very high carb, high fat, and low protein. And unfortunately, when you're giving your body carbs or glucose, large amounts of glucose 3 times a day, it's going to say, this is my primary fuel. I'm going to continue to store this. I'm going to continue to use this as fuel. And if I have a lot of fat, I'm going to store all this fat for later. We were adapted to use that tool, glucose, carbohydrates, as our primary source of food for metabolism, of energy for metabolism, and then that fat gets stored for later. Now, we have the benefit of being able to put food on the table much easier than our ancestors did. So we are now becoming the product of this ease of obtaining really easy energy. I would highly recommend ensuring that you work with your primary care provider to get in front of understanding, what is my risk of developing diabetes? What does my sugar look like over the course of the last 3 months with a simple blood test? But most importantly is understanding how my nutrition affects my sugar levels on a daily basis. If you eat breakfast, lunch, and dinner, the odds are that your sugar levels are doing this on a daily basis. And simply what we can do is change the content of our plate or understand and become educated about nutrition to decrease the risk of those high sugar levels causing or influencing the possibility of developing diabetes. Now, with diabetes and with high cholesterol, with hypertension, we have this framework about what a patient should look like if they're uncontrolled diabetics, hypertensive, or hyperlipidemics. And usually one thinks of having a large neck circumference, large abdominal obesity. But what I want to say is abdominal obesity or obesity in general is a function of what we do on a daily basis. Okay. People that are obese, that does not mean that they have diabetes. That doesn't mean they have high cholesterol. That doesn't mean they have high blood pressure. But ensuring that we control the amount of fat that we have on the body, that inherently can also decrease one's risk, because usually that means that this patient is developing an exercise plan or limiting their caloric intake based on their needs, and not, again, storing all that fat for later when they're not using it. Disease processes such as an increased amount of abdominal obesity or obesity in general leads to disease processes such as obstructive sleep apnea. If you hear your partner at night snoring or catching their breath multiple times at nighttime, obstructive sleep apnea has been associated with an increased risk of developing dementia, an increased risk of developing high blood pressure, and also an increased risk of being inactive. If you wake up and you're tired, if you're falling asleep throughout the day and you're tired, there is no way that you're working out. There's no way that you're moving around. You're likely stuck on the couch and just sleeping the rest of the day to catch up on that amount of sleep depth that you have accumulated. Getting tested early based on your risk of having obstructive sleep apnea is really important, because again, we spend 1/3 of our life in sleep, and we want to make sure that we are sleeping appropriately, we're getting enough oxygenation to the brain. And if we already have arteries that are clogged with cholesterol, that lack of oxygenation can actually be harmful to our health. Now, we do our absolute best in stroke care to manage your risk by identifying, one, what caused the stroke, and then two, how can I mitigate that risk? So we develop treatment plans based on that are tailored to you by giving you medications to decrease one's risk of forming a clot, say aspirin, or anticoagulant medications such as the ones that are used in atrial fibrillation, Eliquis. We want to make sure that you're on the right medications to control your individual blood pressure. Make sure that you're on a cholesterol lowering agent or stabilizing agent, such as a statin medication, to decrease your cholesterol to a healthy level. Treat your diabetes appropriately. Ensure that you're treating your obstructive sleep apnea with the appropriate CPAP machine, exercising, and eating a Mediterranean diet. So if you look at this patient as a whole, one who has not had a stroke, one who has gotten in front of their background, knowing my family history, where I live, what exposures I have, and they go to their primary care physician and say, hey, what is my stroke risk? And if you have controlled blood pressure, controlled cholesterol, controlled sugar levels, you're exercising, sleeping very well, and eating an adequate Mediterranean diet based on your caloric needs, you're doing absolutely everything you can to mitigate your risk of having an event. The last thing that I want to make sure that I mention is, even if we do all this, there are times in our lives and individual bodies and patients where we cannot stop the formation of clots. And this may be inherently with genetic diseases that exist within the family. So becoming informed and educated about the diseases that exist within your family, in addition to modifying your risk factors and understanding that strokes come from the heart, the vessels in the neck, the vessels in the head, and what you do on a daily basis, all that comes into play with the ultimate goal of preventing and decreasing your individual risk of having, again, a heart attack or a stroke. So with that, I will take any questions that you can place on the chat, and Suzanne is going to help me kind of field those questions, if that's okay.
Yep, absolutely. Thanks so much for that great presentation, Dr. Gonzalez. I do have a couple of questions. You mentioned the Mediterranean diet. Is that the only diet that the American Heart Association supports to decrease stroke risk?
The Mediterranean diet is the diet that the American Heart Association endorses at decreasing one's risk of cardiovascular events. Now, there is also a second diet referred to as the DASH diet that's specifically used in patients with high blood pressure that, if adhered to, patients mitigate their risk of having high blood pressure or high blood pressure symptoms or diseases that are secondary due to high blood pressure that unfortunately can affect the kidneys, the eyes, and the heart in different ways. The Mediterranean diet is specifically what we recommend to all of our patients when they enter the Barrow Stroke Clinic here at the Petsnick Stroke Center.
Great. Thank you. Do all medications for blood pressure and cholesterol have the same effect at decreasing stroke risk?
That's a wonderful question. Medications they target specific parts of the body. So let's say that blood pressure, for example, we can control blood pressure in oversimplification two ways: by making you pee a little bit more and decreasing the volume within those arteries, or by decreasing the strength in which those arteries are contracting, kind of like opening up the arteries and kind of having them take a breath a little bit. Different medications are necessary for treating blood pressure in patients, say, that have diabetes or heart failure. So your blood pressure medications should be tailored to your background. Now, if you don't have any disease processes, if you don't have any comorbidities like high blood pressure, diabetes, we can use almost any type of blood pressure medication, almost. But ensuring that you're on the right blood pressure medications for your disease processes is exactly the recommendation or the questions I'd be asking my primary care physician. And secondly, not all statin medication is created the same. There's different types of cholesterol-lowering agents that may be given via subcutaneous shots, meaning through the skin, self-injection. So it sounds worse than it is, but it's very easy for our patients to obtain. It's very easy for our patients to deliver. Secondly is oral medications such as statins. There's high intensity, moderate intensity, low intensity. We always want our patients to be on higher intensity medications. And also, we can also decrease cholesterol absorption through a by-mouth medication. So different medications specifically tailored for those patients. Say if they can tolerate statins, we'll go to the injectables or the by-mouth medication that works primarily in the gut.
Great. Thank you. We do have a question. One of our participants would like to know if there's a more specific age range or race that's at risk for stroke.
That's a great question. So the minority populations are at an increased risk of stroke. And this has been studied through like Asian Americans, they have a higher incidence of patients having arterial blockages inside of the brain. Patients that smoke, you would expect them to have strokes at a younger age. So depending on your background, yes, strokes can occur. Depending on your specific genetic makeup and your background, strokes can occur earlier. Primarily, we see patients that are older than the age of 55. That age group has specific disease processes, say heart disease or cholesterol of the arteries in the neck, that we entertain more frequently, that we treat more frequently. Now, when patients present with a stroke below the age of 55, or say even their 20s and 30s, our kind of antennas go up and we start looking more for like the genetic causes, the inherited causes, or the patients that kind of acquire diseases such as their immune system getting confused. And we tailor our diagnostic workup to these known disease processes based on when the stroke occurred and their age. Primarily, we do see patients above the age of 55, 65 that have suffered a stroke, and we treat those accordingly.
So in the younger population, then what would be the biggest risk factor?
Illicit drug use, trauma, those are the primary risk factors that we see in patients causing stroke. So believe it or not, even small amounts of even THC in the younger years can affect the blood vessels in the brain in a much more dramatic fashion because we don't have that ability to inhibit those reward pathways like adults do. So refraining from any kind of alcohol consumption, THC consumption, at all is the goal, but making sure that during those developmental years that your kids are avoiding that at all costs. those can be very deleterious to their health and have long-term implications, some of which that I wish we could study, but it's just not ethical to 100% do so. But we know that they can be very harmful. We can be very harmful in this patient population. So abstaining from any of those illicit drug use, easier said than done, trauma, are the two main mechanisms to decrease one's stroke risk.
Right. I think that looks like it for all of our questions at this point. So I just wanted to thank you, Dr. Gonzalez, for this wonderful presentation. Thank you everyone for participating. This webinar is part of a larger program called Neurology in the News. So each month you can be kept up to date on things related to different neurological conditions. We appreciate you joining us and have a wonderful day.
Thank you so much. I appreciate the time. Have a wonderful day.
Thank you.